Hello and welcome to the ISPAD 2020 virtual workshop by Medtronic entitled Successful Initiation of Automated Insulin Delivery Systems in 10 Days, both in clinic and remotely. My name is Ohad Cohen. I am a Director of Medical Affairs for Diabetes Medtronic in Europe, Middle East, and Africa. And before I introduce our expert, Professor Goran Petrovski, I would like to discuss the background of the COVID-19 epidemic. Now, this epidemic, with its tragedies and challenges, actually provided us the opportunity to reassess some of our practices, especially in the onboarding processes and the follow-up of our patients, that traditionally we were doing it face-to-face. But in this changing reality, we had to adapt. Now, it started with a scare. In the beginning of the epidemic, when you saw on the right the increase in mortality of patients due to the COVID-19 infection, and especially the effect that it had on people with diabetes, both type 1 and type 2 diabetes, there was a worry that based on previous times of issues in which there was a limited of resources for our patients with type 1 and type 2 diabetes, there was a real worry that with number of days that the resources were limited, there was a prediction that the control of diabetes will deteriorate at a time when actually good control was needed to prevent complications of the COVID-19. So it was very surprising that the results were actually paradoxical. If we've seen from the first reports on people with type 1 diabetes who were using automated insulin delivery, the MiniMed 670G from Trieste, Italy, Tonesse and al., they already showed that in the most difficult, I would say, to control population, the adolescents, young adults, they were following the 13 patients, and they saw that actually the glycemic control improved during the reduced morbid and the complete lockdown. And then actually following another 10 to 14 individuals in Tel Aviv in a clinical study that started before the COVID-19 and then during the COVID-19, again, the same phenomena that people who were using technology did not deteriorate, even slightly improved. And last but not least, an observational study from the US in which hundreds of patients who are now remotely onboarding the 670G system, and they were compared to historical onboarding patients, saw that patients who were onboarded virtually had more or less the same outcomes than historically face-to-face, and actually the time of onboarding was even shorter, and the satisfaction of the patients were even higher. So this was quite surprising, but I would say that one of the people who were not surprised was our expert. So I would like to introduce Professor Goran Petrovski. Goran Petrovski right now is a professor of medicine and pediatric at the Sidra Medical Center in Doha, Qatar, and is also a professor in the affiliated Weill Cornell Medicine in Qatar. Now, he was not surprised because he has been dealing with a structured, short onboarding protocols of the technology even before the COVID, and during the COVID, he was also able to adapt to the new situation in which the face-to-face and in clinic visits were limited, and to provide insights and provide outcomes that surpassed many of the clinical studies we have seen up to date. So to tell us how to really onboard in a structured, short, and very effective way in times of regular face-to-face visits, but also how to convert it to virtual sessions, I'm gladly to present my friend, Professor Goran Petrovski, to show and to start the workshop. So please, Goran, the floor is yours.
So thank you, Ohad. Hello, everyone. Good morning, good afternoon, or good evening on this virtual event. It's my pleasure to share with you our experience on MiniMed 670G, the hybrid closed loop. So in the next 30 to 40 minutes, I will be focusing on the following. The 10-day initiation protocol for MiniMed 670G in children and adolescents previously treated with the multiple daily injection. Actually, the practical and the clinical aspects on this protocol, the 1-year clinical experience, and the data on the 670G, which is accepted for the publication in the Acta Diabetologica in September 2020. Then I will move on the virtual initiation for the hybrid closed loop, which is modified protocol on the 10-day initiation protocol and our experience during the COVID-19 pandemic. And we will end up with the case study. So this is a case that how we initiate the MiniMed 670G virtually in the patient during the COVID-19. So let's start. This is the 10-day initiation protocol. So this is our protocol from the multiple daily injections to automated insulin delivery system. Actually, this protocol, it consists of 4 stages. The first step is the MiniMed 670G system compatibility assessment. And this is 2 days, 2 visits of 1 hour duration. Here we are going to evaluate the eligibility criteria for the patient, the system introduction, expectation, and the patient responsibility. The second step is the system training. We do the 5 consecutive days of the training. So usually it is in the afternoon, 2 hours each session. Group education of 3 to 5 patients and their families, and we start the sensor on day number 1, and then at the day number 5 we do the evaluation of the pump readiness for the auto mode initiation. The step number 3 is the manual mode initiation. So we start the open loop with the sensor-automated pump with the suspend before low. We do the CGM review because we have the 7-day data from the previous training days. We do the carb ratio adjustment, and we start the auto mode. And we evaluate the auto mode readiness. So the patients are staying only 3 days in the manual mode, and after that, after 3 days, we initiate. This is the step number 4. We initiate the auto mode. So actually, the auto mode is only after 3 days in the manual mode, and we do the carb ratio adjustment if needed. And then we have the blended follow-up visits, which can be in clinic and also the phone visits. The patients are also doing the CareLink downloads at home. So that means that most of the visits can be done by phone visits because we have the data online. So let's go with the first step. The first step is the 2 days, actually 2 different days for the introduction. And in the first session, so those patients who are interested in the pump therapy, we invite them to join our group introduction session. It's a 1-hour session in person, and now we are doing also virtually. So 10 to 12 patients and the parents who are interested in the pump therapy, we're going to invite to join our session. And the main topics that are discussed. So we have the pumps in the front of us. So we give the pumps to fill the pump. We are discussing about the SmartGuard auto mode functioning. And also we discuss a lot about the patient expectation and the patient responsibilities. I think that this is one of the crucial points for the further going with this protocol. If the patients are not ready, because maybe some of them, they said, I don't like to go further, then it's fine. Those who are interested, they will be invited for the system readiness assessment. So this is the second day, another day, 1-hour session. It's in person, which means that we do the evaluation of the carb counting. If the patient are doing the bolusing for the carbs, bolusing for the correction, and if the patient, the meaning of the sensor calibration. If the patients are not ready on this point, then we will repeat the education is needed. So if the patient is ready, then we'll go on the next step. The next step is the system training, which is the 5 consecutive days. And even on the previous visit, on the introduction session, we explained them the full flow of the 10-day initiation protocol. So that it means that they need to follow 5 consecutive days at the clinic, 2 hours in a group session. So this is the education that we are doing for our patient. This is the 5 days, and these are the training topics. 2 hours each session, 3 to 5 patients in each group. So on the day number 1, we do the introduction for the MiniMed 670G, the glucose reading display, and we start the sensor on the day number 1. We use that one also in the previous pump because we found it that it's very important, because on the following 5 days, because the patient are coming to the clinic every day, so they will experience experience the high, the lows, the alarms, the calibrations. So we have more time to do the necessary changes and to do more education if needed. So all this training, the 5 consecutive days, actually it's a combination of the medical and the technical training. So on the day number 2, we are discussing, so we are giving the education on the bolus wizard, the meal correction, how to pump, how to disconnect the pump, and about the minimal mode, the basal rate, suspend before low. And then we go also with the smart guard, auto mode, the auto basal and the safe basal, how the pump is functioning. Day number 3 is for the practical points, infusion set change. So the patient needs to know how to change the infusion set, and also the alarms and alerts on the suspend before low, and also the alarms and alerts in the auto mode. Then day number 3, it's also focused on the caring software. So all the patients here, they have their designated user and the password. They bring their laptops at the clinic, which means that they should know how to upload the pump to the care link, because most of the visits after it can be virtual by phone or by Zoom or the other communication channels. Day number 4, it's on the management of the special situation. So this is the pure medical condition on how to treat the low glucose levels, high glucose level, how to approach the diabetic ketoacidosis, what to do in the sick day management, exercise, how they can use the temporary target, and what to do when they are traveling. The day number 5 actually is the assessment on the previous days, the automat readiness. So we evaluate all topics listed above. So we go also the automat readiness screen. So we are focusing again that for the MiniMed 670G, the most important point is the bolus before the meal, and also how to troubleshoot the automat exits. And then the third step is the manual mode. So after these 5 days of education, the patient will start the manual mode, so the open mode, open loop, the suspend before low, and then we have the CGM review, because we have 5 to 7 days the CGM data, and we do adjustment of the carb ratio immediately if needed. So because we have the data here of the previous 7 days, we evaluate the patient readiness to initiate the automat. So we are discussing about the sensor calibration, the carb counting, and the bolus timing. Like in this case, we can see that there are missed calibration. So that means that we discuss in front. So we want to be sure that the patient will do the proper calibration even before initiating the pump. Then we define the pump settings on the regular clinical settings that what we are doing. We have the auto generator, which generates the pump setting, and then we do the fine tuning if needed based on the previous 7 days CGM data on the MDI. So we do the basal rates, the glucose targets, the carb ratio, the sensitivity, and the active insulin time, and we initiate the manual mode with the suspend before the feature. So the patients are staying only 3 days in the manual mode, and we found that it is enough to initiate the auto mode. So this is the step number 4, which means that we initiate the auto mode. So we evaluate the patient readiness to initiate the auto mode. So we have the 3 days in the manual mode in the open mode. So we are going to evaluate the sensor calibration, the carb counting, if the patient is doing the proper carb counting, the meal bolusing, so the timing if the patient is bolusing before the meals, and also if there are correction bolus if needed. And then we do immediate adjustment of the carb ratio if needed, and most of the time the active insulin time is not changed. The follow-up visits, it's a blended one, so it means that most of the visits can be done remotely, online, because the patient knows how to download the pump at home, and we have the data in our system. So the follow-up visits consist of the assess of the patient engagement on the sensor usage. So we want our patient to use the sensor at least 80–85%. Then the auto mode usage, again, more than 80 to 85%. Also the sensor calibration, if the sensor calibrations are quite okay. If the patient is doing the carb counting, the meals per day and the bolusing, the time of the bolus. And if the patient is giving the correction, again, with the auto mode exits. And then we do the adjustment of the system settings, mostly on the carb ratio. And I can say that from our previous experience, the setting adjustment in the first month is very crucial, because if we are adjusting the carb, mostly the carb ratio in the first month, then after the first month, we're going to see the better results, and these better results can be maintained over the next couple of months. So the next point that I want to share with you is the 1-year clinical evidence. Actually, this is the previous study that is published in the beginning of the 2020. So it was the 10-day structured initiation protocol for multiple daily injections to the hybrid closed loop system in children and adolescents with the type 1 diabetes. So the first 3 months are published, and now we follow the patient for the following 9 months. So the design of the study was prospective, single arm, single center. So we included 30 children. We recruited 30 children and adolescents aged from 7 to 18 years. The first 3 months were published, and then we have an additional 9 months follow-up for the hybrid closed loop. So the objective was to evaluate this 10-day initiation protocol for MiniMed 670G hybrid closed loop system in people with diabetes type 1 on multiple daily injections in achieving desirable glycemic control. These are the inclusion and exclusion criteria. So these were the children and adolescents aged from 7 to 18 years, clinical diagnosis of the type 1 diabetes. They should be on the basal bolus therapy with a total daily dose more than 8 units over a 1-week period. They should have the A1C below 12.5 on the recruitment, and they should be willing and able to upload the data on the KLink software and the history of 3 clinical visits in the last year. The exclusion criteria was the diabetic ketoacidosis 6 months prior the screening. These are the baseline characteristics of our patient. As you can see, the age was 10.2 years, because these were the children and adolescents. The ratio of the male and female was equal. 50% were male and 50% were female. The BMI was normal, and the duration of the diabetes was 2.8 years. So the total daily dose units per kg, it was 0.8 units per kg, and the baseline hemoglobin A1C was 8.2%, which is higher compared to the other studies performed of the MiniMed 670G. Another interesting point about the previous sensor use, we found that the 20% were using the real-time CGM, 33% were using the intermittent scanning, the flash monitoring, and almost 50% they had no prior experience with any sensor, or any diabetes technology. So they were purely multiple daily injections with the glucometer, with the self-monitoring of the blood glucose control. So we took this advantage to see how we can initiate the MiniMed 670G, the hybrid closed loop, immediately from the MDI and the SMBG. I can say that maybe this is one of the most important slides, which shows the glycemic control during the 1-year period. So as you can see here, that all the 30 patients, they finished the 12-month period. So there was no attrition, no dropouts. So all the 30 patients, they finished the 1-year follow-up. So the data on the left-hand side is the multiple daily injections and the CGM data. So this is the 7-day. Then we have the 3 days in the manual mode. And after that, as you can see here, is the Smart Guard Auto mode. So we have the data for the 3 days, the first month, and then we have 3, 6, 9 months, and the 12 months follow-up. So as you can see here, the sensor glucose mean was 193, so it was a little bit higher. And after the first 3 months, we decreased to 142, and it stayed around 140 over the 1 year period. So the baseline A1C of 8.2%, it was decreased to 6.7% in the first 3 months. It was amazing result, and it maintained below 7% on the following 1 year, and we ended up with 7.1% at the 12-month follow-up. So let's discuss now about the time in ranges. So the time above the range, the time in target range, and time below the target range. So as you can see here, the time in target range on the MDI and the CGM, it was below 50%, almost 47%. When we initiate the open loop, the manual mode, it was decreased to 56%. And just in 3 days in the auto mode, we were able to get the time in range of 65%. I can say that maybe this high time in range only after the first 3 days in the auto mode, it is because of the 2 points. The first point is the automation, so the algorithm of the MiniMed 670G adjustment in the basal insulin delivery, and the second point is that we were more aggressive in the changing the carb ratio. So when we evaluate the 3 days of the manual mode, if we see that the postprandials were high, even in most of the patients, if needed, we change the carb ratio immediately within the initiation of the auto mode. So after the first month in the auto mode, the time in target range increased above the 70%, so almost 72%. As you can see, in the 3 months, it reaches almost 75%, and in the following 3, 6, 9 months, and 12 months, it maintained above 70% during the study and ended up at almost 73%. What about the time above the ranges? We can see here that during the MDI and the CGM, it was almost 50% time above the target, which is significantly high. And during the manual mode, it was decreased almost to 40%. When we started the auto mode, this percentage was decreased almost to 23 to 24%, and we ended up with almost 24% time above the range. What about the time below the range? It remained very low with the international consensus of the target range. So it means that it stays below 4% for the time below 70%, and it was only 0.3 at the end for the time below 50 milligrams per deciliter. I want to stress that there were 0 severe hypoglycemia, 0 diabetic ketoacidosis, and there were no hospital admission. And I want to stress again that all 30 patients, they finished the 12 months of the follow-up, so no attrition, no dropouts during the first year. And what is very important now, because this patient we are following after the 1 year, I can say that after 1.5 years, that most of the patients, they finished now 1.5 years, they are still using the MiniMed 670G. So what about the system characteristics in the auto mode? As you can see, this is a little bit busy slide, but we want to evaluate the system characteristics over the 1 year period. As you can see here, our patient, they use the sensor almost 90%, and during the 1 year period, this it was the high engagement with the sensor wear, so they use almost 90% of the time they use the sensor. It was the same with the auto mode. So we started with 85% and we ended after the 1 year almost with 85%. So that means that the patients were highly engaged with the pump. So they use the sensor as we instructed, and they use also they stay in the auto mode more than 85%. We can see also that we started with the 4.3 calibration in the first 2 weeks, and then it was significantly decreased to 3.4, and it stays almost around 3 calibrations per day. I can stress that the high calibration in the first period were based because all these patients were used to check their blood sugar 6, 7, or 10 times, because they are mostly MDI, multiple daily injections, using the SMBG, so the pure glucometer. So what about the carb ratio? So like other studies, we noticed that we need to change the carb ratio. So on the baseline, we started the auto mode, it was 16.2 grams, so 1 unit for 16.2 grams. And then in the first 3 months, we significantly decreased to 12.8. So this was about maybe 20% decrease in the first 3 months. But when we analyzed deeply the data, most of the changes we did it in the first 1 month of the auto mode initiation. In the next following 6, 9, and 12 months, we were changing the carb ratio slowly without the significant difference, and we ended up with almost 10 with a carb ratio of 10. I can say that this is mostly fine. We found this data because most of the patients were children and adolescents, and they need more and more insulin because they are growing. What about the active insulin time? We didn't find any significant difference in changing the active insulin time. So we started with almost 3.6 hours and we ended up with 3.4. So one of the conclusions is that when we start the auto mode, we need to change the carb ratio, but we don't need to be so aggressive like the active insulin time. When we analyze the auto mode exits per week. So in the first 2 weeks of the hybrid closed loop in the auto mode, there were almost eight exits per patient per week. In the first 3 months, they were decreased to 4, significant decrease, and they stay almost about 4 exits per patient per week during the 1-year follow-up. I can say that this data shows that the patients were more confident to use the pump in the first 3 months, and they were also engaged with the pump. The total daily dose, we didn't find any significant difference, so we started with 0.8 units per kg, and we ended up with 0.9. Another interesting finding, we found that the basal insulin during the first 2 weeks in the auto mode, it was 36.5%, and it was increased more than 40% in the first 3 months, and it stays more than 40% in the following 1 year. I believe that this data shows it's based on the algorithm, because we have the automated insulin delivery in the basal insulin. So what are the clinical outcomes in the 1 year when we are talking about the glycemic control? Because now when we evaluate the glycemic control, we want to evaluate the A1C and also the time in the target range. So at the end of the 1 year, the average A1C was 7.1%. This is the average in all our patients. And one of the most interesting findings that 73% of the participants achieved the hemoglobin A1C below 7%. What about the time in target range? So it was 72.8%, the average at the 1 year follow-up, so almost 73, and this fulfills the criteria of the international consensus for the time in target range. And another excellent data from our study finding was that 68% of the participants achieved time in target rate more than 70%. And this is the 1 year follow-up data. So what we can say, what are the clinical points for the successful initiation of the MiniMed 670G hybrid closed loop? So the first point is the patient selection. So in our 10-day initiation protocol, we focus mostly for the patient who are interested. This is the introduction session. We discuss with the patient about the expectation, the responsibilities, and motivation. We put the focus on the calibration and the bolus before the meal and bolus for the correction if needed. So if the patient fulfill the criteria, then they will go to the next stage. What about the therapy management? We need to evaluate the patient engagement. So we want our patient to use the sensor more than 80–85% and to stay in the auto mode. And because if the patient is staying in the auto mode, we will have the better control. We need to evaluate the glycemic control, both A1C and the timing ranges. And we need to perform the system settings. Comparing with the previous pumps, this is much easier because we only just need to change the carb ratio if needed. So there are also physician tasks and patient tasks. The physician task for the MiniMed 670G is to reassess the carb ratio if needed as of the manual mode initiation. From our experience, those with because these patients were children and adolescents, that means that they will grow, and like the others, we need to change them even the carb ratio. But for the adults and those with established type 1 diabetes, adults and maybe some of the adolescents, when we assess and set the carb ratio, we don't need to change. And the setting adjustment in the first month of the auto mode is critical. And also the physicians and the health providers, they need to trust the system. What are the patient tasks? So the patient needs to calibrate the sensor, which means that they will stay with the sensor and they can stay with the auto mode. They need to bolus before the meals. They need to bolus for the correction if needed. And also they need to trust the system. There's also a protocol book on this on this clinical experience. So you can ask your Medtronic representative for a copy. It's almost 34 pages. It's straightforward, so it can be useful in your daily practice. So let's move on the third topic, which is going virtual. So what about if can we initiate remotely the MiniMed 670, the hybrid closed loop in the patient with type 1 diabetes? And this is the next topic that we want to discuss. Before going on that, I can say that diabetes is a unique condition and it's a good platform for the distal technologies. As we can see from the left-hand side, when we have the patient with the type 1 diabetes, most of our patients are using some kind of the technology. Maybe they are using the pump, the sensor, the glucometer, the insulin pens. Via the Bluetooth technology, all these devices can transfer the data to the mobile phones, and using the 4G or the 5G or the Wi-Fi, this data can be stored on the cloud server. From the other side, this data can be shared with the caregiver, mostly with family, with parents or the family, so they can see in the real-time data. So this is what we have on the market. From the cloud server, this data from the pump, from the sensor, from the glucometer can be shared with the electronic medical record. So the diabetes specialist can get the data online. So it means that we can communicate with our patient to use the different channel. So we can call the patient, we can use the SMS, we can use different application, we can use the social media or different portals to communicate as a medical feedback with the patient and the diabetes specialist. So that means that we can go virtual because all the data that we needed from the pump, so from the insulin, from the glycemic profile, and also the carbs, it's stored in the cloud server. So we can use this kind of the advantage during the COVID-19 and to move forward with this remote approach. So we are all faced with the COVID-19 pandemic, and we were all prompted to find the new and innovative way to treat our patients. So with the COVID-19 pandemic, we can say that the world was almost stopped. When the COVID-19 hit Qatar in March 2020, all the diabetes services were disrupted. I work in the tertiary clinic. It's a COVID-free hospital where all the services were switched as a remote consultation. But what happened for the patients on the MDI who needed to initiate the pump therapy? We already had previous long waiting list for the patient who will need to initiate the hybrid closed loop. What about the patient who were already scheduled for the pump initiation? These services were stopped. They were not considered as crucial service and they were postponed. So previously we have presented the 10-day initiation protocol in person in the group training, how we can initiate in the patient with the previously treated with the multiple daily injections. And then we ask ourselves, can we initiate the hybrid closed loop virtually? So when we ask our patient if they want to proceed with the virtual onboarding, 85% of the patients who were ready for the pump therapy, they wanted to initiate the pump virtually online during the COVID-19. So can we start the hybrid closed loop without the clinical visits? Yes, we can. So this is what we did. This is the previous in the initiation protocol. 2 days in the manual, 2 days introduction, 5 days, consecutive days of the training, face-to-face, 3 days in the manual mode, and then we have the follow-ups. This is how does it look like in the calendar view. As you can see here, we have these are the first introduction session. Then we have the carb counting evaluation assessment before going. These are the 5 consecutive days of the training in clinic, 3 to 5 days. Then after 7 days, this is the weekend here, we start the pump in the manual mode. Then we initiate the pump in the auto mode, and then we have the follow-up visits for the auto mode. So this is how it looks like in the clinic. When we design the program to go virtually, so this is almost the same, but we have 2 additional visits. So as you can see here, this is the introduction session, this is the assessment, and then we have the technical assessment before going, and then we have the pre-pump training. As you can see, the 5 consecutive days are here. They are virtual, they are using the Skype Meet now, but they are moved from Wednesday till Thursday. We found it more practical to move it like this because they will have more time during the weekend to practice at home. Then we have the with the yellow one is the evaluation, and then we have the starting the manual mode, and then we have the auto mode in the initiation here, and then we have the follow-ups. 2 additional visits that we needed for the virtual onboarding is the two sessions. The first is the technical readiness, so it's about maybe 15 to 30 minutes. We validate the availability for the following: if the patient has the laptop with audio and video, because we need to have the video communication because it's online using the Skype Meet now. We have to be sure that the patient has the good internet connection for home. The patient needs to have the email address, the Skype account, and we create the Calic account. So this is the technical readiness. And then before starting the 5 consecutive days virtual, we have the pre-pump training, which is around 30 minutes, which means that the patients are advised to do some pre-work, to read some basic stuff, some basic reading from the guideline and from the user guide, and to watch the Medtronic videos about the 670 pump basics, the menus and the setup, how to change the infusion set videos, and the sensor insertion. So this will be very important because for the next following 5 days. So these visits, because they are virtual, they are a little bit different from the previous one. Because the previous one, when we gather the patient in the room, the patient, our educator will teach them, will educate them how to use the pump. So they have the pump in the front of them, and the educator can go with the different families and they can show them. So here it's a completely different story. First of all, we use 2 cameras, so which means that one of the camera is above the pump, and when the educator is teaching the patient virtually using the Skype Meet now, the patient from the other side can see these menus and how the educator is moving from one to another patient, or from one to another menu. The second point is that the evaluation, because it's a virtual, we have to develop other points. So the first one is the assessment, which means that this is how the session starts. The educator will assess the patient families' understanding on the topics covered on the previous day. So it means that we need to confirm that the patient and families completed the homework. So it means that the patient are ready to move for the second topic. And then with the education is the training on the new topic on the MiniMed 670. And the end of the session, that the educator will give the homeworks. So it will be the reading of the specific topics in the user guide. They need to watch the specific videos, the Medtronic ones, and they have to practice and record the specific tasks. So they use their mobile phones to record, let's say, how they change the infusion set, or how they bolus for the food, how they bolus for the correction, and how they insert the sensor. These videos then will be sent to our educator. Educator will evaluate, and then they will make the assessment. If there is a need to re-educate, they will focus again. and then the patient will do again the recordings, and it will be sent to the educator for the evaluation. So we're going to end up with one of the case study. So how we virtually initiate the MiniMed 670G. So this is one of our cases. So this is Mona, the 13 years old girl, diagnosed at the age of 8. The current therapy before going on the pump, it was total daily dose of 40, so 0.9 units per kg. Long-acting insulin of 14 units, the carb ratio of 10. Then we have the sensitivity factor of 100 and 120 milligrams. It was the target. No diabetes-related complication, normal weight and height, and the baseline hemoglobin A1C was 8.9%. From the food history, the patient has 2 to 3 main meals, some snacks, and the basic carb counting. No regular exercise. This was during the pandemic, the COVID-19, when almost everything was stopped. So from the social history, the patient was a friendly person. So they have requested to use the MiniMed 670G, and because of the pandemic, they obliged to go on the full remote onboarding program. So we did the Skype calls, the Skype meet now with the patient. So we do the 5 educational days and the previous evaluation, the pre-assessment on the technical assessment. So this is the MDI and the CGM, the 7 days data. So we can see here that we have 49% of the sensor usage, which is a little bit low. The time in range of 36% is acceptable because the patient was the MDI with the A1C of almost 9%, and the 3% of the time in the low glucose values. So we need to evaluate the weekly report and to see what's going on with this sensor usage. So we can see here there was a low engagement with the sensor calibration. As you know, this is the virtual patient, this is the virtual onboarding protocol. And then we educated the patient how to do the regular calibration. So we advise the patient to do the 2 to 3, mostly 3 calibrations per day, and to have this continuous glycemic, to have the continuous sensor use. What we did, we educate the patient on the calibration and also the sensor. Then we started the manual mode, again virtually, and I can say that from the educator point of view, this was a little bit tricky, because filling the reservoir, filling the cannula, filling the cannula, it was a little bit tricky, and we want to be sure that the patient will fulfill without the bubbles. So what we observed here, there is a high sensor usage, so almost 95%. The time in range, it was increased to 57%. And then we can see here that on the overlay, in the percentile comparison, it's a little bit high during the day. So we need to review the weekly report. Maybe we need to change the carb ratio and to evaluate the engagement of the system. So this is the 3 days in the manual mode. As we can see here, it's a good engagement with the sensor. Some boluses are not given before the meal, and the carb counting seems maybe some inaccurate in some instances. So we re-educate about the carb counting again virtually, and we decided to change the carb ratio from 10 to 8, starting the auto mode. And this is the first week, again virtually using the Skype. The patient downloaded the pump. The pump at home, so we have the data in front of our computers. We see that there is a high sensor usage, so the auto mode of almost 98%, high sensor where few exits here, so only 3 exits. Time in range increased to 77%, excellent, and there's a 0 time in the hypoglycemia. So no specific action should be taken here. So there are some highs here a little bit, but we don't want to change because it's only the first week in the auto mode, so we need to give the system to adapt the changes. So this is the first week. So some highs after the meals, and then we stress the point that the patient needs to bolus before the meals. Then this is the second week in the auto mode. We can see here that the high sensor and auto mode usage. So only one auto mode exit. The time in target range, it's perfect, it's excellent, 88% with 1% with the low glucose values. So we don't need to do any specific action here. we just need to continue to follow up. We ask the patient to download the pump in the next 1 month, so after 2 weeks from the previous virtual remote visit. What we can see here, the time in target range, 88%, perfect. And we can see that it's a high sensor in the auto mode usage here. Only one auto mode exit, and only 2% in the hypoglycemia. No specific action should be taken here. And this is the 3 months data. Again, we can see that the patient is the high sensor in the auto mode usage, more than 90% for both auto mode usage and the high sensor. No auto mode, few auto mode exits, 81% time in target range, and no hypoglycemia, only 1% in low glucose values. So we don't need to do any specific action. Again, we need to congratulate Mona for the successful initiation from the multiple daily injection. This is on the weekly report. It's a good engagement, and we want to applaud the success with the parents and also with this teenager. So as a summary from this patient, as we can see here again, this is how we started. This is the MDI and the CGM, only 36%, some hypoglycemias. The manual mode in only the 3 days, 57%. And in the first week, we achieved 77% time in the target range, and it was maintained over 80% in the first 3 months of the year. So this was the virtual patient, the virtual onboarding. The patient was normal at home and with the family. As you can see, time above the ranges, they were decreased to 80% with almost zero hypoglycemic. The time spent in the low glucose events are almost zero. So what we can conclude, what are the key take-away messages? So the initiation of the MiniMed 670G system in the 10 days individual and the multiple daily injections therapy demonstrated over a 1-year period to be safe, no diabetic ketoacidosis, no severe hypoglycemia in all patients, achieving glycemic targets, so improved hemoglobin A1C, improved time in target range, and decreased time below the below range, and also decreased time above the range. And it was appreciated by the user. There was no therapy in discontinuation. All 30 patients continued to use the pump after the 1-year period. It is demonstrated to be efficient in both individuals, experienced or not experienced with the CGM or the flash monitoring, and also the MiniMed 670G and the protocol. It demonstrated to be efficient in both in clinic or the remote. So the remote initiation should be offered to individuals who are interested in this type of the therapy, and additional requirements like internet connection, video communication, and the basic communication skills are needed. So thank you for your time.
Thank you so much. Thank you so much, Goran, for this immense and amazing work. Before we go to the 15 minutes that we have for Q&A, and there are several questions, very interesting questions to bring to you. Again, thank you a lot for this effort and this presentation. I just want to mention that Medtronic, following your good experience and actually consulting with you, has now can provide specific modules for total, I would say, remote onboarding modules for each of the devices from Medtronic. So all the issues that you have brought for technical readiness and for the hands-on experience can now be received from Medtronic to do this remotely. That means safe onboarding of both the pumps, sensors, infusion sets, and all you have to do is connect with your TC or your representative from Medtronic to gain access to this. So let's start with the Q&A. And some of them are very interesting. Before we start, I just want to mention that you have found that having the patient use the pump in the first week as actually a monitor, a sensor, providing them time to get used and train on the button pushing on one hand, and for you to learn more under CGM patterns, so when you start manual mode, you'll be smarter. Did I get it right?
Yes, Ohad, thank you. Thank you for this. I think that this is not the new concept. And even with the first pumps that we have it, like the VO pump or the first sensor-augmented pump therapy, the VO pump, and also the 640G, our training protocols in Sidra and back in Macedonia was that we start the sensor for the training. So we copied the same protocol, and it means that we don't want to start with the two different tracks in the same time. So in this week of education, either it is virtual or in clinic, the patient would get used on the sensor alarms, maybe some differences, and if they will have the questions, and we'll be with them and we'll answer. So they will be more confident when they will start the pump, and even for the sensor, with the real insulin delivery. So all the patients will be ready to start the automation. So they will be more confident from one side, and then from the other side, we have the 7 days of the CGM data, which means it will be used as a starting point for the basal rates. But for the 670, it was a little bit more further, because we use this data even to fine tune the carb ratio even before starting the auto mode. So we have the 7 days of the data of the CGM on the MDI, and we have another 3 days in the manual mode. And even for some of the patients, about maybe 20-25%, even we decrease the carb ratio for more insulin even before the automation started.
Fantastic. Okay, so that's clear. I just wanted to make this is a very important point, and I think that's interesting and a wise use of the technology when you onboard. So some short answers to a short question, which is very technical. So during the lockdown, were you able to do group practices, or how many were you able to connect at the same time? That was one of the questions that was asked.
So I think that, in Qatar, there was no full lockdown like we saw in Italy, in Spain. So I think that it was moderate lockdown. We were able to go out and, to have some physical exercise. But with the
session, in the clinic.
Yeah, the session actually, because the clinic was closed, and we just immediately switched virtually. And then we are going to the clinic every day, and then our patients were staying at home. And those patients who needed the pump therapy, who were scheduled, because the COVID-19 just happened immediately, they were pushing us, when we'll start the pump, and going every day to the clinic. And sometimes we stay at home. We said, why don't we start to initiate the pump from home? So thank you for bringing this out, that we have now the models from Medtronic that can help us. And it's a good opportunity to use this point. So for the first patient, we started only with one, because it was, and even our educators were not so confident to start the virtual one. And we said, okay, let's start with one patient, and then the next one was with 2 patients, and then we can go with maximum of 3 patients in the same time.
Fantastic.
So
you were able to have 3 patients on the same Zoom meeting, and actually it worked.
Yes, it worked. Up to 3 patients, I can say that it can work. It's a little bit difficult with the educator, but now we are thinking to develop, to have 3 or maybe 4 patients, and then 2 educators from behind.
At the same
time. Because
fantastic.
on the in-clinic, when we are doing 4 patients, or even we did it with 5 patients, then we need to have 2 educators on site.
Okay, so you're saying that up to 3 patients, you already tried this and it works okay in the cases. So here comes the second. That's why I want to push, because there's a provocative question, right? Because you're showing such a great results. Maybe in your process of selection, especially the first 2 meetings, which you select the patients for, you're only selecting the best patients. So my question is, when you go through this process, how many patients actually do not fit and you find them unfit for the technology? And if you have patients that do not pass the first 2 meetings, okay, you just give up and say, okay, go continue with MDI, or what do you do with them? So how many are they? And do they go through another process to give them another chance?
So I think that, this is it's not the study, it's the clinical process that we are doing at CIDRA. So that means that all the patients who are referred for the pump therapy, they should meet some criteria. So one of the first criteria is to do the carb counting. So the carb counting is the must. So that means that they need to do the carb counting before. And then on the introduction session, so the introduction session that we did it for the 670G, because it was immediate transfer from the MDI to the 670G. We want to be sure that we will communicate, we will present to the patient what are their responsibilities and what they need to expect from the pump. So the expectation, how they will accept the pump. I can say that not more than 20-25%, they cannot continue with the pump therapy immediately, but they will stay in the same tier until they fit the criteria. So it means that if you have the patient who is referred and then you invite them to come on the introduction session and there's no show, how you proceed for this patient? So that means that this patient also needs to appreciate the technology. So that means that the patient should be there. And even, when we're, some of the patients who are referred, they think that it's a fully automated system. So that means when we explain for them, maybe they will go home, they will think about that one, they will speak with the families, with some other patients, and will say, okay, if this is the best solution, I will go for that. So that means that they will not proceed. And this is not only for the study. This is what we are practicing the last 3 to 4 years.
Day to day. So you say 25-30% at the initial funnel will not go straight to the technology. They are either they're going to be recalled again, or wait, but those are more or less the numbers. And for this specific presentation, they're not specifically good or specifically chosen. If that was the
no, it's not specifically chosen.
Okay.
First come, first served. This is the way how we're doing. So actually, after the study, after these 30 patients, we initiate with the same protocol the other patients. So that means that we are continuing the same pathway. So our educators are the same, so they know it's a clinical pathway. It's not the study.
Cool.
So we have to think about the vice versa.
It's actually observation of what you did, and you saw that actually it shows that you're doing the right way because you get good results. Now, there's a question for both of us, both from you, from your medical center, and me from Medtronic, and that is, how much do you utilize in this pathway the staff from Medtronic? Are you doing it all yourself, or are you doing it combined with Medtronic in let's say in Qatar?
So for the virtual one, I can say that we did it completely by ourselves. So because it was something that, we were all shocked what happened. And also for the other, actually, I can say that maybe 90-95% of all tasks are performed by the center. Only some technical points, if something is wrong, then the Medtronic stuff, it's here. So we want to be some kind of independent,
So I know you, and I know Sidra and how you work, and you really do most of the work almost exclusively by yourself. But from Medtronic side of things is that you can be provided, each one of you on a call or whoever is working with technology can get access to onboarding virtually that can be either done 100% by you as physicians, or 100% after you provide the settings by the Medtronic staff, or actually doing it in combination, that somebody from the clinic and somebody from a TC from Medtronic on the same Zoom, coming and going and doing it in a combined way. So everything is open. You know what? Exactly how you are used to do this pre-COVID or pre-virtual. Because some of you in the clinics do it by yourself, some actually call the TC and he sits in a different room, and some of you combine it together with your nurse, educator, or physician. So the same is now provided by these modules by Medtronic.
So I want just to add one point that, when we have the upgrades, the old pump to the new pump, so we use the Medtronic staff for the upgrades. So they will do the old technical stuff, but our educators, after that, they need to do the re-evaluation before starting. So because from the medical point of view.
So I got to push some interesting, they want to know some of more your knowledge on the pump therapy. And that has two questions. So I'll give you quickly because we have 3 minutes. One, why do you choose 2.5 hours for active insulin time? Why not 3? Why not 4? And the second question, how did the variability of the patients change while they were onboarding from MDI to 670, the CV. Did it change much? If you don't have, I can answer the last one. You take the first one on active insulin time.
So I think, we don't need to do a lot with the active insulin time. So even, we were following, so I think it was 3.5 hours. So there was no significant difference. So we used 3 to 4 hours and we're not focusing on that. Even, all our data is showing that the active insulin time is not so significant to spend time to evaluate, to analyze. Of course, if you put 2 hours, I'm talking about the children and adolescents, so it can be a little bit, maybe you have to re-evaluate. But 3 to 4 hours, it's enough. Once you start, you don't need to change. The only thing that we have to re-evaluate is the carb ratio. And if we are evaluating the carb ratio in the first month, it's crucial. Once you set, it's quite okay. These are the children and adolescents, especially for the children because they are growing. The need of the insulin will be increased. And we have to do the fine-tuning of the carb ratio in the future. For the adults, because we have almost young adults, once you set the carb ratio, it's the same like the old pump. When you set the basal rates, the bolus wizard setting, it will be the same.
Fantastic. So to make a short story out of the question, in 670, you can choose 2.5 hours, 3 hours. In the auto mode, it doesn't really matter much. In the manual mode, it matters more. And by the way, when we going to introduce the new auto corrections, it'll be more important again. So important in the manual mode, not important in 670. Maybe in the future, when you're going to start autocorrection, it's going to be, again, important to use a shorter time. And for the last question, for the CV, which is a measure of variability, that means the standard deviation divided by the mean, you're going to see something very interesting, because when you use the technology and you get more time in range and almost no hypoglycemia, you might even get a small increase on the CV. And I'll give you an exercise. If your standard deviation is 40 and your mean blood glucose is 180, your CV will be 22. Well, let's say if you decrease the mean to 120 and decrease the CV, the standard deviation to 30, you increase your CV. So the coefficient of variance for the new devices will be not the right way to study variability, but this is an open scientific questions for our next meeting, maybe, Goran. And with this, I think, you any last words before we conclude because of the time?
I think that when we have, the patient on the 670 or the hybrid closed loop or maybe advanced hybrid closed loop, we have to be sure that the patient is spending time in the auto mode. So staying more than 80-85% in the auto mode. So we have the time in range above 65 or 70%, and also the low glucose, the time below rate should be below 5%. So these are the 3 critical points, when we are evaluating. So the CV, from the clinical point of view, I can say that it's less important. So we can discuss, but when you have the patient in the front of you, you have to fix the diabetes, and the patient should be happy and to enjoy, to have the quality of life. So we don't want just to push that we have a perfect glucose control, but the automated insulin delivery, it will give the quality of life for the patients.
And I think with this, improving the quality of life, but without giving up outcomes, so having both outcomes and quality of the life, this is where automation insulin delivery and the therapy of type 1 diabetes should lead to. And with this, I want to end and thank you all for joining us. And again, Professor Goran Petrovski, thank you all for your work and your presentation here. And I hope you're going to have the rest of a good conference on the ISPAD, and hope to see you in our future workshops and meetings, and have a great day. Thank you so much.
Thank you. Thank you, Ohad.